The first speaker is going to be discussing genetics and risk factors by Dr. Manish Shah from the Weill Cornell Medical College, New York Presbyterian Hospital. So I'd like to introduce him, and please come up to the podium. Thank you. And again, all of those who are, in the audience here, if you have any questions, please write them down on a card. We will be having a Q&A session. All those people who are online right now, please feel free to send me your questions online.
Thank you. So, thank you very much for inviting me. I was very touched by the initial panel. I think as a physician, and many of us are in the room, we're reminded by how strong you have to be a patient and a caregiver. A lot of what we do is actually for these guys. So, with that, I'm very humbled. So it's an honor to be here to talk about epidemiology and genetics. And actually, to be honest, many people in the room here could give this talk, because there are actually several experts in stomach and esophageal cancer. I'm just one of them. And so I will start. So, as was mentioned earlier, esophagus and gastric cancers together comprise 43,000 patients a year. This, in the United States, is not a very prevalent disease. It's less than pancreatic cancer by itself, and about 1/3 as much as colon cancer or breast cancer, 1/5 as much as prostate cancer. However, worldwide, it's quite a significant disease. Almost 1.4 million, if you combine esophagus and gastric cancer, will be diagnosed worldwide. And nearly 1 million people will die every year with these cancers. Stomach cancer represents most of them, 26,000. Esophageal cancer is about 17,000. And then there's this area in between called the GE junction, which, depending on sort of who you see, you might be sort of thought of as a gastric cancer or an esophageal cancer. So that actually, the GE junction tumors are increasing in prevalence in the United States, in large part because obesity and our diet and things like that. So there has been a decline in the incidence of gastric cancer in the West over the last 3 or 4 or 5 decades. However, as I just said, there's an increase in esophageal and GE junction and cardia cancers in Western countries. Overall, our survival has improved over the last 3 or 4 decades. For stomach cancer, it's gone from 15–16% to about a quarter of the patients. And clearly, although that is a significant, substantial improvement, it's not enough. I think we want that number to be closer to 100, obviously, but even more than 50 would be great. Esophageal cancer is a much more dismal disease, and we're just now approaching a 20-year survival if you're diagnosed with stomach or esophageal cancer. So this is a schematic of the esophagus and GE junction, and then the stomach is sort of just below the red area. The risk factors kind of vary as you go from the esophagus to the stomach. Diet and alcohol are, and certainly, hot drinks and tobacco are more prevalent risk factors for esophageal cancer. Acid reflux, obesity, these are more prevalent risk factors for cancers of the GE junction. When it was becoming more prevalent about 15 years ago, it was sort of the Wall Street disease, high stress jobs, people who maybe weren't the most fit, had a lot of reflux. These were the people that were getting it, men more than women. And then for stomach cancer, the number one by far risk factor is H. pylori. This is an endemic bacterial infection. It infects about half the world's population and is responsible for, we think, about 80% of stomach cancers that are diagnosed. It leads to a chronic inflammatory state. which over time can lead to stomach cancer. And this is actually a very common thing across GI cancers, is that chronic inflammation of the mucosa, whether it's esophagus, GE junction, stomach, colon, liver, even pancreas. So chronic inflammation is a bad thing, and these are the things that cause chronic inflammation in the upper GI tract. Having similar problem forwarding slide. Let's see. I don't know. Can someone forward the slide for me? Sorry. I think the next slide is a picture of Marshall and the people that discovered H. pylori. And the intent of that slide is to sort of talk about how prevalent that H. pylori is in stomach cancer. There's an interesting anecdote that the way that they proved that H. pylori actually was the cause of gastric ulcers is that I believe Barry Marshall is the one that actually took the actually. Oh no, we're here. Sorry. So these are factors associated with increased stomach cancer. So we think of sort of different categories: nutritional, environmental factors, so salted and smoked foods, high dietary nitrates. Fruits and vegetables actually are protective. So if you have a diet that's low in fruits and vegetables, then you have a higher risk, and selenium. From a socioeconomic standpoint, it's really a city of dense population. So low socioeconomic status. If you live in the cities, you have a higher risk. Tobacco use is associated with stomach cancer. Prior gastric surgery. So 30 years ago, the main treatment, one of the main treatments for gastric ulcer disease was actually a gastric cancer surgery to a Billroth 2 to sort of remove that area of the stomach. And 20 years later, these patients are actually at an increased risk of developing stomach cancer. We talked a little about H. pylori infection, gastric atrophy and gastritis, and pernicious anemia, which is another cause of sort of chronic inflammation in the stomach. So these are all things that ultimately lead to a chronic inflammatory state in the stomach, which then lead to development of stomach cancer. This is an important slide because it's increasingly apparent that this is an important disease. About 5% of people with stomach cancer actually carry a germline mutation in a protein called CDH1 or E-cadherin. This is a cell surface protein, and it was actually discovered about 20 years ago by Perry Kilford. This first paper in the New England Journal actually highlights the importance of it. So David Huntsman followed a kindred of people who had a high risk of stomach cancer, had a CDH1 mutation in their germline, and he reported on 6 people who had a prophylactic gastrectomy. And endoscopies didn't show cancer, but in each of the 6 patients, there were foci of signet ring cell cancers within the stomach. And this is actually the sort of start of the idea that we should do prophylactic gastrectomies in patients who carry a CDH1 mutation, ideally in their 20s and 30s, to prevent the development of stomach cancer in the future. So this is a pathway looking at the E-cadherin pathway. And so what's highlighted there is E-cadherin. It's a cell surface protein. And when that is mutated, then what happens is that the protein that binds to it, beta-catenin, is now free in the cytoplasm, and then it's able to get translocated into the nucleus, where it actually can activate transcription factors that then lead to the development of stomach cancer. And these are criteria for being tested. So if you have a family history of stomach cancer, particularly diffuse stomach cancer, or early onset, diagnosed before the age of 50, if you have one diffuse gastric cancer below the age of 40, if you have a family history of lobular breast cancer or signet ring cell colon cancer, these are all things that you would consider and notify your doctor about so that you can at least get considered for testing for this. So one of the things that has happened over the last 15 years is that we used to be lumpers. We would think of everything as one disease. And now with our improvement in kind of understanding nuances of disease, both on a clinical level, but also on a genetic level, we are now splitters. We are dividing diseases into disease subtypes. And by doing that, we think that we're going to be able to better identify certain types of subsets of disease that might be better treated by certain treatments or drugs or surgeries. So stomach cancer in particular is not one disease. By histology, which is looking at the slides, you can see that they actually come in two major forms, intestinal and diffuse, very, very different. On location, the GE junction and cardia tumors have a different epidemiology than tumors that are lower in the stomach. In biology, so we talked about CDH1. MET is another protein that actually has a familial component. And then etiology. H. pylori is the main factor, but we think that there may be others. So here is Barry Marshall and Robin Warren. So this is the H. pylori bacteria, that top panel there. And what happens is that this bacteria resides on the right on the surface of the mucosa of the lower part of the stomach. And it's, the stomach is a very harsh environment. It has a low pH. It's where the initial digestion of food happens. And this bacteria has evolved in a way that actually this is the preferred environment. And once it sets up shop, it can do many different things. It could do nothing, which is probably what happens to most people, but it could lead to gastritis, it could lead to ulceration, and probably in less than 1%, probably less than 0.5% of people, it can lead to cancer itself. And these are the people that discovered it. And actually, it was quite revolutionary. I mentioned that the treatment for gastric ulcers used to be a Billroth 2 surgery, but now you can treat this bacteria with a course of antibiotics and proton pump inhibitors. And by doing that, you can actually cure your ulcer disease. So that has really revolutionized that part of it. But interestingly, treating H. pylori does not significantly alter your risk of getting stomach cancer down the line. We think that there's another factor. So we're doing research and looking at the microbiome of the stomach to see are there other bacteria that actually reside in the stomach that may influence your risk of developing stomach cancer. Turns out there are about 100 different bacteria that live in the stomach, and so this research is ongoing. And this is what I mentioned already. So it's an endemic infection present in half of all people, and it infects the gastric antrum, and it causes gastritis, ulceration, and it's what we call a class 1 carcinogen. So it is indeed a clear risk factor for developing stomach cancer. And then I mentioned the differences between GE junction, proximal tumors versus non-cardia tumors. And just looking at the epidemiology, you can see significant differences. So although both are male predominant, the more proximal tumors, GE junction and cardia, tend to be 5-fold more common in men than women. And the ethnic diversity is almost reversed. So the proximal tumors are more prevalent in white or Caucasian people versus black, versus its reverse in non-cardiac cancers. GE junction cardiac cancers have a wide age range, whereas the cardia tumors tend to have an increased incidence with age, and then there's a difference with socioeconomics as well. So in summary, there's a wide variation in global incidence of stomach cancer. It's not so prevalent in the United States. The incidence is declining, whereas it's very prevalent in South America, Eastern Europe, Asia. It's related in part to H. pylori infection, related to diet, other factors. Barrett's esophagus and esophageal cancer and GE junction cancers are actually increasing in frequency, and we need to understand that better. We think it's, at least in the West, related to industrialization. So increased access to food, obesity, reflux, these are the reasons. And we think that molecular drivers will lead to new therapies. And that's actually the next part of this disease, this talk. And just from a genetic standpoint, I mentioned about hereditary diffuse gastric cancer. That's the CDH1 mutations. But there are other hereditary syndromes. Lynch syndrome is associated with stomach cancer, FAP, Li-Fraumeni syndrome, which is a mutation in P53, and Peutz-Jeghers syndrome as well. So talked about global heterogeneity and subtypes of stomach cancer. So we think of stomach cancer now from a conceptual risk of genetic risk, environmental risk, and behavioral risk. And so I've included some of the factors there. One thing I didn't mention is at the top, it's the immune system and the polymorphisms in the immune system. And so what that is that, I mentioned that H. pylori is prevalent in a lot of people. Our body's reaction to H. pylori is different, though. And so polymorphisms in IL-1, IL-4, these actually affect the way that our body actually reacts to H. pylori, such that some polymorphisms are associated with actually a overactive immune system leading to chronic inflammation, and that actually increases your risk for stomach cancer. The odds ratio for that is 3 to 4. And so we actually thought of stomach cancer and disease in different sort of disease subtypes. The non-cardia stomach cancer, which we've talked about, relate to H. pylori, the diffuse stomach cancer, which actually doesn't have a location prevalence, and then proximal stomach cancer seem to be different as well. Several years ago, we analyzed from tissue biopsies that were done actually when I was at Memorial to look at by the expression of genes to see did these 3 types of stomach cancer actually truly exist, and in fact they do appear to be different. And if you do a molecular analysis, you can see that the expression of genes actually are quite different between the 3 groups, suggesting that they are in fact 3 different subtypes. This idea of subtypes of stomach cancer has actually been worked on for many, many groups. Ian Tan from Singapore has a very nice paper from a few years ago looking at over 521 patients and 37 different stomach cancer cell lines, and he's developed a molecular analysis to identify a genomically intestinal or genomic diffuse stomach cancer. And on the right there you see a heat map where you have red and green, and it basically highlights genes that are upregulated in one type and downregulated in another type. And actually what's very interesting is that this genomic analysis in some respects is actually more accurate than us looking at a microscope to sort of see is the tumor intestinal or diffuse, which is actually quite challenging because our sample size or what we can view in the microscope is a very small set of it. And then finally, Adam Bass, who I think has spoken at Debbie's Dream Foundation and is one of the scientific members, led a analysis of the TCGA, and actually Elena and David Ilson and David Kelson were part of that from Memorial as well. And they contributed samples to sequence over 200 stomach cancers, and they actually identified 4 major subtypes of stomach cancer. The chromosomal unstable subtype, EBV-associated subtype, microsatellite unstable subtype, and genomically stable subtype. And each of these subtypes have different characteristics that are listed here. The genomically unstable subtype tends to be intestinal, mostly in the GE junction tumors. There's a high rate of P53 mutations. Microsatellite unstable subtypes are associated with a high amount of promoter methylation. The stable subtype is the diffuse gastric cancer subtype, and then the EBV subtype, which we really don't see in the United States, but in this panel set was about 10%, is associated with high expression of PDL1 and 2, which may be important for immunotherapies. So putting these all together, the risk factors, the immune SNPs, and the subtypes that we've defined, the paradigm actually is kind of complicated. It's not one disease, but several different subtypes. I think that's the future of how we will manage this disease, is we have to understand the subtypes that we're treating to treat them better. And this is just sort of one example. So PDL1 and PDL2 are proteins that are involved in immunosurveillance. And you can see that some subtypes, particularly the EBV subtype, has a higher prevalence of these markers, which may suggest that these subtypes are more likely to benefit from immunotherapy. So this is just one example of that. The converse is the genomically stable subtype, which is the green there. There's almost no expression of PDL1, which suggests that this tumor may not be sensitive to immunotherapies. And in fact, we have a clue of this when we look under the microscope, because in diffuse gastric cancer, you see individual cells throughout the matrix of the stomach, but there's no association with immune cells. Whereas other subtypes of stomach cancer, you can see a very robust inflammatory infiltrate. So we had the clues before. We're now able to assign them based on molecular characteristics. And that's actually where we're heading for stomach cancer research. And this is just an example of the importance of that. So PDL1 negative tumors, these are the ones that actually don't activate the immune, or sort of allow for surveillance of the immune system to be active. They have actually a better outcome than the positive tumors. So the implications of all this is that subtypes of gastric cancer do exist. From a patient standpoint, you have stomach cancer, it's a big deal. But from a physician standpoint, when we're treating a patient, we want to understand the genetic modifications of that specific subtype, because we can tailor therapy better. So, one thing from an advocacy standpoint is to actually support and educate patients about the importance of getting biopsies and getting re-biopsies to try to get more tissue to understand this better. Our ability to interrogate tumors is much better now than it was even 10 years ago. And so even with a small amount of tissue and sometimes with blood, we can actually learn a lot. And these subtypes do explain already some of the differences in response to therapy and prognosis. And sort of the catchphrase is that tumors have different molecular drivers, and these drivers have different therapeutic targets. And that's why we do it. I think that's my last slide. So thank you very much.